Good morning, everyone. Thanks so much for coming to hear about this great story about a very unique and very positive collaboration between Frontier Direct Care and the City of McAllen. And today we have two panelists and then the founder of Frontier here today. But first, my name is Sean Kelley. I am the managing partner and founder, co-founder of Texas Medical Management. We do bundled surgery across the state of Texas. We work with these fine people today and are expanding our relationship everywhere they are. So today, our panelists, we have Jolee Perez, Joe Wilson, and then why don't we start off with introduction? We'll get Dr. Peter Lazapina to give you a little bit of the origin story of why he started Frontier and the changes that it has helped health plans across the state of Texas.
Hey there, I'm Dr. Pete Lazapina. I started Frontier in 2018. I'd been working at a residency program, which I loved. I taught residents for 7 years. It was really cool. We got to do full scope family medicine, working in a hospital, in the clinic, delivering babies in the ER, all the things. And it was fun. But over the years, I'd see my residents learn all these things and then go out and hate their job and hate their lives because they were working all day, doing notes all night, and frustrated with the bureaucracy. And then I stumbled on direct primary care, went to a couple conferences, FMMA included, and was like, man, this solves the problem. 90% of the problem is solved in primary care if we start doing it direct. I told my residents for a few years, like, hey, you guys, you don't have to work for the man. You can go out and start your own practices again. But of course, in training, you always hear it's too hard to be a good doctor and run your own practice. And that brainwashing is difficult to overcome, besides the golden handcuffs and all the other obstacles to starting something that's new and different. And so after a few years of that, I decided I needed to start doing direct primary care in our community. And we live in one of the poorest counties in the country. And so just in that, everybody said, oh, everybody's on Medicare or Medicaid. This will never work here. And I knew that if we could make it work in Cameron County and in South Texas, we could make it work anywhere. So we got that going. And within a year and a half, I was running full and ready to start growing. And I was trying to talk to people like Jolee and brokers, and they just kind of laughed me out of the room because in my naivete, I'm like an idealist. And I said, this is the best way to do it. We should just start doing it. I know there's barriers, but forget it. Let's just go. And they just laughed me out of the room. And so people like Joe, my good friend here, and my partner Bib and Joe got involved and came up with the solutions working with people like Jolee that actually allowed us to implement direct primary care in a scalable way that addresses all of the barriers to doing direct primary care in a health plan. So it's been really cool. Jolee and Joe are going to share some of the solutions and how things have worked in doing that.
Thank you.
Dr. Pete's first desk and exam table was a massage table and a picnic table in a rented room at a missionary chapel in the worst part of downtown Harlingen. So, and he had 20 patients. So just want anybody out there that's a physician or trying to get in this know that we started from scratch. This wasn't something that we all came from medicine or anything. So now we'll get to the rest of the story.
Fantastic. Thanks, Joe. Jolee, thank you so much for coming up. I think this conference is so much richer because of the participation of employers, especially employers who've actually made the big decisions like you in the City of McAllen. Why don't you tell us a little bit about the City of McAllen, your role with the city, and some of the challenges you've experienced managing health plan?
So, again, my name's Jolee. I've been the Director of Employee Benefits for the city as of today, 15 years. However, at the time before we launched the DBC, I had been in the business about 12 and a half years. And quite frankly, I ran 1,900 employees, 2,000 on average, eligible. We actually had some retirees and some agencies that get into our plan. And we had been struggling so bad in those 12 and a half years that I had basically thought about leaving the industry because I hadn't been making any mark. We had been fighting this uphill battle. On average, we were fighting anywhere between a $5 to $7 million deficit every year. Our satisfaction rates were extremely low. I joke about it, but I was afraid to go out at the end of the day to see if my tires were slashed. You know, it was one of those things. The plan had been managed in a way that we were doing everything to try to cut costs. So there was cost shifting. There was the limitations, the quantity limits, everything that everybody's told to do to manage their expenses, we had done. And we had done that successfully in a way that we were actually better than book of business on most of our metrics. So we could be proud of that. However, at the end of the day, our budget wasn't getting any better. It was only going exponentially up. And again, that satisfaction and our health, it was all going downhill. And so that challenge was something that had really gotten to me, and I felt like there was no way I was ever going to be able to fight this giant, and there was no way we were ever going to move a metric that actually made a difference for our plan at the time.
Wow. You were in a tough spot. And so thank God you met Joe and Dr. Pete. Joe, why don't you tell us a little bit about Frontier Direct Care? I know Dr. Lazapina explains kind of the origin, but why don't you tell us a little bit about what it looks like today, your role, and kind of outline for us some of the initial experiences you had with the City of McAllen?
Yeah, so like Dr. Pete shared, we were founded in 2018, but at that time it was what is DPC, and he was just doing this thing kind of alone, and we were kind of watching it like, let's see if anybody actually signs up and moves over from seeing you at the hospital to seeing you at this new location that was really rough. And so, you know, and then after we saw it and watched it, it was, I think in 2019 that we decided, let's start looking at this a little bit deeper. And in 2020, we kind of pulled the trigger and said, let's go. And so in March of 2021 is when we really started trying to work with employers and start selling to small groups. And I'm talking like 5-person family farms, right? That was where we started, and we were pushing medical cost sharing as kind of a big solution with DPC, or maybe you got a high deductible plan and can do this as a individual. And we started trying to hit with brokers, and they just were giving us the stiff arm on anything. And we finally got one group that was 40 people, and they had a fully insured program and got a 40% renewal, right? So they were like, anything could be better than this. Mm-hmm. They reached out, and we kind of showed them, hey, you can raise that deductible, lower that premium, afford DPC, and let's start fixing this claims issue, right? And then over 3 years, get your population healthy and back into a place you could look at level funded and stuff like that. So we started that first clinic. Now we're at 140 employees, 100 employer clients, roughly around 30,000 members under contract, with 10 plus clinics across the state of Texas. You can see down here on the bottom picture, that's the Rio Grande Valley. So number one there at the very bottom is in Brownsville, Texas. So you could hit a golf ball across the river and be in Mexico. So we're talking a very diverse community. Well, I would say it's not diverse. It's just, and so it's, but it's a very culturally rich community that we've been able to establish this in. But walking into Jolee's office, that was something that was really fun. Our friends at Salazar Insurance Group, PJ, was like, hey, I think the City of McAllen needs to hear this. And Jolee's the one person I know that I think can understand and get all this. And I literally walked in with somebody else's one pager and said, I think we can do this for you. And we thought we might get 30 minutes, and she gave us a full like hour and a half. And I was like, she's letting me keep talking and she's not stopping me, so I'll just keep going here. Mm-hmm. And so that was the first part of it, and then we'll get into more of how that integrated in the next couple of questions.
Okay, thank you. So as a consumer myself for the past 12 years of direct primary care, I know on a personal level and a familial level all the value that it brings to you as patients, as people trying to live healthfully. I know the value of DPC. I think the big divide has been, how do we bring it to corporations? And I know there's a lot of people trying to experimenting on a lot of different levels, but I want y'all to hear today the relationship that Jolee and Joe and Dr. Pete created here, because it is very unique and it is very powerful. And we'll see the results here in just a minute. So talking about how you first met and everything, how did the City of McAllen go about vetting or understanding who Frontier was and how as you, as the person in charge, the director of benefits, how are you going to implement something like this?
I think at first I did a deep dive into what DPC was. They had given me some resources to look into, and I read every one of them. Some case studies that were out there, and white papers that had been written. And I think as I read more, I drank more of the Kool-Aid, and I could see it. And I really I really developed that vision of what my population could receive for healthcare. And so that's the dream start. That's like, okay, this is what we want. How do we get there? And I'm a municipality, so I've got to get through several levels of approvals, including 2 elected boards that we have to get through. And so that vetting process has to be more than just the dream, right? We ran some numbers. We did our best with numbers because, quite frankly, there wasn't much to go on. As far as we didn't have any peers locally that were doing it. We as far as municipalities and school districts that I could call and say, what are your numbers and how can we use them? So we did a lot of, if this happens, then this, and trying to get those numbers to what we thought were realistic. In fact, we tried to go very conservative with those first numbers because we didn't want to go so high that if we missed the mark and we were able to do this, then we wouldn't be doing it for very long. I think it. We also talked to a couple of their customers, tried to get some testimonies. Even the person that brought it to me was a patient of theirs, and he had his own testimony. And so that helped. I really liked the patient testimonies to be able to say, what kind of care are you truly receiving from these people? Is it what they're telling me they can do, or is it a lower level of care? And so those testimonies were huge. We also did site visits. So at the time, they had a few facilities. And so we went to one in our town that they had just. I'll let Joe talk about that, but we went and saw the site, and the site made a lot of sense to us, and we're like, okay, we could see ourselves here. And so we just kept asking a lot of questions, and every time they had an answer. I think that they had practiced and rehearsed, but some of them were probably off the cuff because we asked some really weird questions at times.
No, they were all well thought through. Yeah, absolutely. It was, working with private employers, it was usually the CEO's making a decision or HR's making a decision. Maybe sometimes there's 3 stakeholders making a decision or a benefits committee. Sometimes pretty rare, especially in groups under like 500 lives, right? And so, but then going and work with a municipality where there's elected officials and taxpayer money at play, right? Like there's a real vetting process that everybody's putting their necks out here, and they want to make sure they get reelected and keep their jobs. And so this thorough process taught us a ton, and getting asked those questions helped us even prepare our own business better. I would say the toughness of going through this and Jolee's attention to detail made us as a DPC 10 times better than we ever were before. And so I think that vetting us we were also vetting the city of McAllen. Like, can we do this? Are they in this with us? And last night we were talking with Rachel, and she said something that's really powerful is we also had to know that on the other side of the table, we had a partner that wasn't going to quit, right? Because this is going to be a lift, and it's going to be hard. It might not be hard on the employees. It's actually pretty easy on them. But it's very hard on the staff and, our customer success people, our physicians, getting those new people, trying to meet all those expectations when here come, 3,600 people or 3,200 people in the first couple of months. It's like, this is going to be hard on some people. And so to have that relationship where we were vetting each other, she's vetting us for our business acumen, we're vetting them for their ability to kind of stand and deliver this together with us was very important. We also did a lot around updating our marketing and stuff. So she was asking questions, she was leading us through, you're going to have to represent this way to city council. This is how they'll understand it. And so having that, I would say, mentor in the process, leading us through there was very important, but it took a lot. Like, this was something, when you think about it, Dr. Pete alone could not have done this, right? It was important to establish a team, to align on goals. And so I will give you one tip of advice is if you are starting to scale up, we use a book called Traction, and it's just an easy business and entrepreneur operating system, but it allowed Dr. Pete, myself, who came from ministry, and Bib, who came from construction, to have a working, method and a target and goal that we were achieving every quarter. And so that's how we were able to marry up to what the county or what the city was asking of us.
Well, you've touched on a little bit on the what Frontier had to do to implement DPC. You talked about your biggest client being 40, and so I'm sure you were picking up some others, but smaller industries. But picking up somebody with 2,000 people, tell me a little bit about the lift that Frontier had to take on.
Yeah, I mean, I think that's hard to think about. And as I've been around the direct primary care community, the free market community, Health Rosetta, like there's a lot of, we want to go work with employers, right? But then we have this challenge of your DPC panels, 600, 800 people. The self-funded market's going to be starting at around 200 employees for the most part. Like that's what you're probably going to find where they're able to take these chances. But that can be a fairly high risky move for a company that small, right? So the market really is kind of more upstream, and to think about taking on 1,000-person group where you can really have massive impact, well, that's another 2 providers, right?
Mm-hmm.
And then to think about taking on a 3,000-person group, well, here comes 6, 7, 8 providers that we need to build for. In addition to, if they each have their own exam rooms, here's 8 more exam rooms we got to build, and we need to serve the census of the city of McAllen and make this very convenient. So we studied their employee census, built clinics near the neighborhoods where they lived, not necessarily where they worked, because when you're sick, you don't go to work, right? You stay around your house. You can maybe go get some chicken noodle soup at Chick-fil-A and come back. And so we were looking at those locations, what was convenient. One funny fact was we called Jolee and said, all right, we got the second location picked out. Here's the address, whatever, Edinburgh, Texas. And she goes, no, it's not. And we said, yeah, it's just right across the street. Like it's in, the county, and like McAllen is like right there on the city line. And she goes, yeah, but it's across the street. And we said, okay, understood. And then we called her back about an hour later and said, okay, the address is now McAllen, Texas. We rented one across the street here. So, accommodating, collaborating with them, because the city wanted to stand up proud and say, look, we brought business to our local community. The health plan we're now running, the direct contracts, those things going on are establishing cash staying in our city. It's establishing a better foundation economically for everybody involved. And so we partnered with them in that and said, okay, we got it. We'll move to serve the city in the city.
Okay, now, Jolee, let's talk a little bit about the employee and health plan member response and engagement. So what was your strategy for open enrollment and employee education? And give us a little bit about the employees' perceptions of those changes.
Sure. So we believed that this was not something that was going to be able to be launched with just handing them a newsletter or handing them a flyer or sending an email. To really be able to resonate with this new culture of healthcare that we wanted to provide, we felt like it needed to be in person. And so we decided that we were going to hold in-person meetings an hour and a half long for every single one of our employees in small group settings. We held over 100 meetings in 30 days. It was intense. We went out to the departments and we got them by their groups and we presented. And we presented, I like to say that we preached better than a Southern Baptist preacher on a Sunday morning. Like we went out there with a passion because, again, remember, I was cynical before this. This re-engaged my entire hope in the healthcare system. And so, we wanted to be able to present it with a passion, and we wanted to be able to present it with stories. We wanted to be able to put the employees in a position where they could see themselves in what we were discussing. If they couldn't see themselves in this new model by the time they left the room, then we weren't going to have them from day one. And so we made sure that it was not a quick meeting. It was not a 10-minute announcement, 20-minute. We actually went through, what does this model look like and what does it mean to them and their families? And of course, we had all the supplemental marketing pieces, the flyers, the frequently asked questions, all of that stuff that we were then able to give them, the visual aids. But I think for us, that intentional meeting with each one of the employees from the start is what launched us into a successful a start of our program. And we know it did because one of the things we told them in those meetings was, make your first appointment right away. Don't wait until you have some ailment or sickness, because they want to get to know you. They want to get that history on file. They want to start your checkup now. And then that, if you're waiting until you have an urgent care need, then they've already been established with you and they know who you are and who your family is and so forth. And so what we had at the beginning was we actually had so many phone calls and appointments that were made that we were actually booked up the first almost 3 months. I think it took us to finally level out. So we had to do some triaging with appointments to make sure we could still see those that were sick versus those that were just trying to get into their initial appointment. So we know it worked because it was such a successful educational campaign because they got excited about it.
So that's what we call a good problem to have.
Yes.
People lining up to get appointments for things like this.
Yeah.
That's fantastic. Well, can you share with us some of the key results and financial impacts?
Yeah, and I'll take this real quick on. And so one thing that we had to do, and just kind of coming back to this slide, and I do want to talk about that, was as we get into the results and to the satisfaction, we were trying to use all the tech out there and put together the stack, and we knew that they needed reporting quick, and we needed to be on large population claims data reporting and population health, and we needed to prove our value consistently, not one time, not on a projection, but every day when they ask, here's what's going on, and be the person with the answers. So we had to build our own EHR, billing, eligibility, communication platform, referral platform. And we had a handful of direct contracts at the time. I think we probably had 80 or something like that. And Jolee's like, these are my pain points. Those direct contracts are nice, but I need these ones. And so we went out and built another 230 direct contracts in the local community that could truly carve out the network usage. And we were referring to those same places, but on a cash pay price. And all of that was coming through direct to the city. So they knew exactly what they were paying for the services their employees needed. And those employees were being referred by their dedicated PCP doctor, right? So we didn't need prior auth. It was like, this is needed. And so was really big there. But then you think about that, trying to work with that employer over the 3 months that she's trying to onboard them, we're investing $700,000 of cash in building, hiring, affording those salaries to train them for that month before we're ever getting any revenue from the city. And that's the DPC model of, hey, your clinic is included in this membership. We're not asking the city to float this cost for us, right? So that was a big thing. But the biggest part was measuring patient satisfaction. And so it was important we established those NPS surveys, so Net Promoter Score. And so we built that into every patient visit, that we would then sit down with the patients, or after they visit, they get that simple survey and they respond. And so I would say from day one to now, it's stayed at 94, 95 the whole time. But I'll let you speak to kind of some of the skepticism and wins too, especially some of the stories are pretty fun.
Yeah. So right away we started having stories. The members that were going, having their initial appointments, using it for urgent care. We started having the stories of, this is so great. I love that I could get in and not have to wait in a lobby for 2 hours for a 5-minute appointment. I had time with my provider. So all that feedback started coming in fairly quickly. I have a story that one of my fellow directors, who I had worked with for 12 and a half years at the time that we launched, I didn't even think she liked me, really. I kind of avoided her. I don't think we clicked very well. And one day she came up to me in a parking lot after a director meeting. She walked right up to me and she hugged me. And I kind of freaked out. I was like, what is this? I'm like, what's going to happen? Is she going to pull a knife and shank me? I don't know where this
No
is
longer
going.
the tires they're after.
Right. And so she's just like, you don't understand. Frontier has changed the life of my family. And so she went to tell me about some things that had happened with her son and just, her own health and the way that they were getting treated over there and the things that had happened. And it was just really touching to me. First of all, that somebody who didn't like me suddenly, was a fan of, something I was doing. But more importantly, that her life had changed and her family's life had changed. And that means something for not only her, that also means something for me as an employer, because now we're going to have higher productivity, higher satisfaction. And then it also means ultimately, hopefully, lower expenses. And so on the, we had that initial skepticism. We still had some people out there that, didn't want to change from their current provider. They're like, well, I've been with my my primary care provider for 15 years. They know me. I'm like, okay, that's great. Would they call you if you stopped showing up today? If you weren't seen for 6 months, hadn't had your labs, would they contact you? Would they care that you hadn't been getting care? And they started, no. They probably wouldn't. I'm like, oh, okay. It sounds like they really care about you. And so, we try to talk to those people. And generally what would happen is as we started telling them stories, and as we started getting them, ideas of how they could use it, even if they weren't going to give up their other doctor, we started seeing them shift. And that was really great. But we also had growing pains in the beginning. And so because we were so successful with that launch, we had issues, little things that happen along the way in any course of business. And so if you have somebody talking negatively at a department and they're friends with their friends and they start talking, that could really be detrimental to our entire program. So as soon as we heard anything that didn't go the way it was expected, we weren't afraid to address it. And we weren't afraid to address it not only from staff, but also from Frontier's end. And so we actually would address it head on, explain, what happened, what we're doing to fix it, how we're going to prevent it. We actually went out back to the departments that had a lot of talk amongst them.
Stood in a parking lot.
At 7 a.m.
humid.
in the morning, or it was like 7:30 in the morning, right?
90 degrees in the valley, so it was very
Right.
humid.
And we showed them that, hey, what we promised is what you're going to get. And when it doesn't go that way, we're going to stand up and say, hey, it didn't go that way. We're sorry. And this is what we're doing to fix it. And this is why we're going to be even better moving forward. And that turned around a lot of the people that were afraid to try it in the beginning and that had been listening to we call it chisme in the valley. It's that
Gossip.
Gossip. And so we think that approach, that head-on approach, showed them that we were fully committed to this.
Yeah.
That we were drinking the Kool-Aid too. We weren't just giving them a plan. We were drinking the Kool-Aid too, because we knew that at the end of the day, our dream was going to be the reality.
And the important part here was that we had a measurable, so there was subjective and objective feedback coming in live for us all the time. And if we got the objective feedback, we could address it and also show like, hey, here is the actual stats, right? Like so when city council was going, I heard this isn't going so well. It's like, well, there's 800 surveys that says it's going just fine.
Mhm.
There's one here that's having an issue, and then it's a user error, or we need to communicate a little more clearer, and here's what we're doing to fix it. And they were like, okay, that sounds great.
So I know everybody's here to hear about patient experience and everything, and it's incredibly important. But I think there's some people want to hear about your financial results. And so in the last couple of minutes, you think you can fill in that punchline, not punchline, but like that huge result that you guys did? Because this
Absolutely.
was not all done just to get kudos from the patients and the city
Yep.
council. There was a bottom line you were trying to.
So even though I was really happy that my tires weren't going to be slashed, yes, we wanted real results. So our primary care utilization went up 66% in that first year alone. And so we had more care that had ever been received than any other year prior to that. At the same time, we had the reduction in costs in the major categories that you can directly link to the replacement by the DBC. So your ER utilization, your urgent care utilization, your virtual care utilization, all of those dramatically dropped in utilization because people were now going through the DPC. What we saw was we had some direct savings that equated to cover the net expenses. So we could say without doubt, these few areas saved us $1.9 million, which was the exact amount that we had spent in the DBC fees. So we had no question that we were receiving more care that we had covered the expense of the program. So now the question was, what did we truly save? And we had to take a look at what we were trending. And so that chart right there shows that upper line is what our trend was supposed to be for those 2 years. So starting back in 2021, 22, that was before we launched the DPC. We launched it in October of 22. We were at $561 per member per month cost. What you see in the blue is what we actually did that first year. So we brought it down to 376. That's a net delta of over $5 million, of about $5.75 million. And so we averted over $5.75 million that first year in claims alone. When we get to the second year, because this is total plan expense, this is pharmacy included, we got hit on pharmacy that second year. So there's a reason why we kind of went up. It wasn't on the medical side, because actually on the medical side, we had a 4% year over year decrease into year 2. So not only did we have a decrease year 1, but we had another 4% drop year 2. So unfortunately, pharmacy hit us bad, but at the end of the day, that's still over $2.15 million that we averted in that second year. So overall, we're over $8 million saved in averted claims, and we're getting much more care than we've ever received. On top of that, we had our high cost claimants that dropped significantly by year 2, and we had not had a drop in high cost claimants in over a decade. And so we all know that one high cost claimant, I mean, that can shoot you pretty far up. So dramatic savings. We were not expecting that overall aversion of claims and that reduction, 15% of trend. That was something that was highly unanticipated. We knew the program would work. We knew that we would cover the costs. We just didn't have a good gauge on how much we were going to save overall until we started running these numbers and seeing the actual output.
Yeah. I think the one thing that we also did is this was us as a raw like DPC at that point. Like the direct contract like workflow was laborious to say the least, and challenging at times, and it was building out, right? So a lot of the times like we weren't getting to these MSK solutions until 8 months later down the plan. Same thing, we brought in a pharmacy partner to do some international pharmacy pieces there, and so that was unique, but that didn't happen till like the end of almost mid-year 2, I think. And so there really was like, this was just doing good relational direct primary care. But what we did find out was now that we had that relationship, anything else we did in the program, it wasn't just being taught at open enrollment or through emails. It was being taught at the point of care, because our providers had the plan in the EHR, right? So they're looking at it going, this is where we can send you and what you can do and how much it's going to cost the city or you. And hey, there's no charge to you, right? And that was the other cool part, is we didn't change their plan design hardly at all. They could still just self-select, go to UHC, move out there, but DPC was available to every member on the plan, so that when they decided it was right for them, or when that need did come up, it was available. And so that was really powerful. It was like, you still got all the choices. We're not removing or narrowing anything. We're enhancing everything, and we'll guide you through it. And if you follow this guide, who might guide you right back to the network, it's going to be free.
I would add that when we were setting it up and we were putting it as a bolt-on to our plan, we established it with no co-share, no co-payment, nothing. And I mean, not only at the direct primary care level, but also in all the referrals, all the surgeries, all the maternities, all the births, everything. And so this savings is even with the fact that we didn't have that share in payment from the members. So now the program overall, we've improved access by having the direct primary care, the no lobby, no wait, the ability to contact, but we also improved the other burden, which is the cost. But I think to have these type of savings, and yet the members at no point are sharing in any of it, and that they actually had that financial reduction in liability as a process. We didn't pass any of the DPC fees on to them.
Yeah.
So,
Well, do you want to do the key takeaways? Y'all want to take a few questions? I think
Q&A is
almost
fine.
up.
We can touch on this real fast. So
Sure.
just some key takeaways is I would say, just to kind of sum up what the elements for here was, actually thinking through your finances. If you're going to attack on an employer market, like as a DPC, like you need to really have probably some business partners in that are helping you be accountable. That employee engagement education was huge. Like, don't slack on that at all. And you're going to have to do it consistently. Every month we're doing it again, right? It's just over and over again.
New hires.
And then continuous measurement. Set in the things that can measure your success or your failure, right? So we can know what's going on, and then have that strong leadership buy-in so we can have that transparent communication to fix what's going on. So that would be my 4 key elements to that. But yeah, any questions or thoughts that you all have, we'd love to take them now.
Yeah, so let's open it up for questions.
So the first thing was to get through my boss, and I sat down and I said, I'm not crazy. I'm like, please know that. I think I've proved that. So hear me out. Here's this thing. Here's the vision. Here's my dream. And luckily he believed in me. And so he's like, I still have lots of questions. I still think, that's almost too good to be true. I hate when they say that, right? It's too good to be true. Why does it have to be too good to be true? And so, I had to work through that with him. He allowed me to take it to the city manager. So our approach with the city manager and the mayor, we actually took it. Do you remember the mayor when we brought the mayor in?
Yes, briefly, yes.
Yes. So we tried to have the mayor. I thought that they would do better preaching to city management and to the mayor. The mayor did not like taking a vendor meeting. And so we actually lost the mayor in the first 3 minutes of that meeting. He walked out. And so luckily the city manager stayed in, and we were able to continue that conversation. I think I've established a rapport with them that they really wanted to hear it from me. That's a lesson learned that I probably wouldn't have had them come in for that. Not that they did a bad job. They did a great job. It's just that relationship had already been built and that trust had been built with them. And so that's a lesson that I learned. Getting through them wasn't as hard as I thought it would be because, again, once we started asking or answering the questions, they really, really respected the amount of time that I had researched, the data that I had, the numbers that we had drawn up in what we thought we could do, the estimate of how many people would have to engage in order for this to have a break-even point. And we were actually, now we know that we didn't even have to hit that much. Our estimate was 60%. And had we only hit like 30% or 40%, we would have been successful too. So I think the relationship I have with them, they knew that they could trust the data that I was, what I was pitching helped. Getting through the commission and the Public Utility Board, I thought was going to be even more of a problem. So we have 2 elected bodies for the City of McAllen that we have to get through separately. And we, again, painted that picture, gave them the story, put them in that position where they could see themselves. And believe it or not, despite a few questions here or there, they were ready for it because they knew the system's broken. They were tired of the system themselves. And I think that's what really led to their buy-in, is that every one of my commissioners had already had their frustrations with the system. And suddenly I was giving them the light at the end of the tunnel that there was something better. So you may want to speak to this, but I know that for us, we do have a large hospital system that's not playing ball yet with the cash pay that we want to do, and they are eventually going to see the numbers.
There are
as a
5
result.
others too, so they got more business.
What's that?
So there were 5 other hospitals too, and they got more business when the ones who don't
Right.
take cash pay.
So I think that's been the interesting thing. We just the one of the main hospitals that our people frequented isn't playing ball yet, and our members, some of them were scheduled to have deliveries there. They actually are willing to change their provider.
Wow.
Because they want the benefit of not paying towards that maternity.
Mhm.
And so the hospital's going to feel it. And I think eventually they're going to have to play ball.
I will say this. One of the funnier parts was, that stiff arm we got earlier. I remember walking into some hospitals and we'd love to do a direct contract with you. I didn't know. Again, I came from ministry. I didn't know what a CPT code was to save my life when we started. So they were like, "What do you want?" And I was like, "I don't like. What does it look like?" And so that conversation stalled and didn't go very well. But it wasn't. But probably 6 months later, multiple hospital systems showed up to our headquarters unannounced with their C-suite and wanted us to talk and said, "What you guys are doing is very cool. We want to be a part of that. How do we do business? We're here. Like, please send people to us. This is what we do." And so they all of a sudden saw that power of referral that we had because we had the relationship, and they realized, hey, we need to be accountable partners to this health plan and to the city. And so Now that was like, we used to have to call and say, can you do a direct contract with us? And now they're calling us. And it literally is. Yeah. And you do have to find those incentives. And that was something like even through like our public relations team, kind of like realizing and educating council members and things like that, making sure like, hey, where do the landmines lie around here that we're going to find at the 11th hour? This person's not for it. We needed to have those conversations. And so that was very important that we did a lot of really good investing in relationships before presenting the idea.
Well, I think our time is up today, and I want to thank everybody for attending, but I would like to get a hand of applause for our panelists.